Hello, everyone, and thank you for joining us. Before we get started with the content we have prepared for you today, I have a few quick housekeeping items. Please note that this presentation has been pre-recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, and other advice. Please take a moment to review this notice. This webinar is part of the Private Practice Sustainability Initiative here at the AMA. Private practice is an attractive option for physicians seeking the freedom and independence to practice in a setting that allows them to provide personalized medical care for their patients and is inclusive of practice owners, employed physicians, and independent contractors. Private practice is an important part of the healthcare delivery landscape, and it has been under intense pressure for many years. The COVID-19 pandemic has exacerbated existing concerns of physician practice owners, but has also created opportunities to change and improve healthcare delivery to patients. I'd like to introduce our speakers today: Taylor Johnson, Manager of Physician Practice Development at the American Medical Association, and Dr. Marie Brown, a practicing internist in Chicago and Director of Practice Redesign also at the American Medical Association. They'll be leading us through our content today. And with that, I'd like to turn it over to Taylor.
Thank you, Megan. Hello, everyone, and thank you for being here today. Today, we're going to talk about navigating the current healthcare landscape, particularly as it relates to COVID-19, the staffing crisis, and administrative burden. Our agenda for today, we will start with some information on the current healthcare workforce landscape. Then I'll turn it over to Dr. Brown, who will give some helpful information on reducing workforce burnout and resources that AMA has to help work smarter, not harder. And then finally, we'll go into some tips on how to plan for workforce shortages and things organizations can implement right now to reduce burden on current employees. It's no secret that the current healthcare workforce is under tremendous amounts of stress. A recent study from the AMA and the Mayo Clinic, as well as the recent market scan, showed that the Great Resignation is very real. I won't read all of the statistics to you that are on this slide, but the COVID-19 pandemic has created stress and burnout levels in the healthcare workforce that is so severe that 1 in 5 physicians and 2 in 5 nurses reported that they are moderately likely or higher to leave their current practice within the next 2 years. There's also been a significant decrease in the sentiment nurses and physicians have towards their profession, as shown in the charts on this slide. So what factors influence the decision to leave healthcare? I've touched on this briefly in the last slide, but the major factors include stress and burnout related to insufficient staffing levels, emotional toll of the job, the demanding nature and intense workload, and feeling undervalued by one's organization. And now I'll pass it over to Dr. Brown to discuss practicing wisely.
Thanks, Taylor and Megan, and welcome all of you. I hope you're sitting down, maybe having a cup of coffee, maybe exercising, and keep in mind, since this is all about being more efficient, that you can increase the speed of this webinar. You have that option on Zoom to increase it to 1.25 or 1.5 times faster, so you can get through this as quickly as you need to. So this is an exciting talk for me as an internist. I loved practicing here in Chicago. I worked for 10 years at an FQHC. When that closed, my colleague and I moved down the bus line, and we were in a 2-person practice for over 20 years. And then most recently, I joined the Rush faculty. So I really enjoyed private practice, the autonomy, the ability to spend as much time as I needed with patients. I could implement a lot of what I'm going to talk about very, very easily because I was the boss. But it is really a team-based approach. So we really need to answer the what's in it for me for your entire team so that some of the innovative ideas and time-saving ideas I'm going to share will stick. So I'm going to go through this pretty quickly because there's a lot of wonderful ideas. I'm going to highlight some simple changes that you can do this afternoon or tomorrow morning, next time you see patients, that you have total control over, that will save you an hour or two a day. I did them myself, and I was amazed at how much time I saved. And that time got me home earlier with less work at home, less documentation at home, and more time with my patients, more meaningful work. The strategy for the number one strategy at the AMA is removing obstacles that interfere with patient care, because that's what we were called to do, this important work. And it is very meaningful and gives us tremendous joy if we can do what we were trained to do and build the relationship, build that trust with the patient, which never has it ever been more important to develop that trust than it has been to get through this pandemic and to encourage vaccination, for example. That's the external environment that we're all dealing with. What we're going to focus on in the next 20 minutes or so is really just the staffing crisis. And you, Taylor, laid it out very clearly that this is across all jobs around the United States, but the impact in healthcare is really never been seen before. And what I'm going to focus on is doing more with less people. Because there is a tremendous amount of waste in our day-to-day, and maybe half the day we could find inefficiencies that we could get rid of. And what would that look like in a typical practice? Well, this would probably be a typical patient in my geriatric internal medicine practice. I'm not going to read all the problem list or the 12 meds she's on, but a typical patient with obesity, hypertension, depression, and diabetes without any pre-visit planning or just any team approach to this complicated patient, this would be a typical experience. You're already late. She's come in late. You have 100 messages in your inbox. You try to do the probably 20 things that need to be done for this patient that day, including her health maintenance. And we haven't even had time to ask her what she's here for. And so you put that hand on the doorknob to get to the next patient. And she says, oh, doc, I need a mammogram, a parking sticker, something more for my pain, and so on and so on. And how does that make you feel? Pretty lousy, because you haven't met her needs. You haven't improved her hypertension and her diabetes. You haven't built trust, and off you go to the next patient. But what we don't think about is what happens between this visit and next. So we're going to see the patient with diabetes every 3 months. She's probably going to call 10, 12 times for the things that we didn't do today. You ordered her blood test today. Now we have to play phone tag or patient portal tag and escalate therapy or ask if she's taking her medicines and so on. If you add these touches up, it's a one staff call here, a second call here, you're looking at a patient portal message. If you add it all up, it's a minute here, 5 minutes there, but it can be 3 to 4 hours per patient that is unscheduled, unreimbursed, and interrupts the regular flow of the patients that you're scheduled to see that day. It's just not sustainable, and we're not going to be able to deliver the quality care that gives us such great joy. So let's focus on efficiency. We also know that physicians are actually more resilient than the average person. Given our training, we signed up for over 80 hours a week in training, so we have some pretty good resilience skills. And it's really the efficiency, the burden, and the culture that we're working in, or the inefficiency, I should say, that leads to less joy in our practice and leads to burnout. So to do this work, we want to celebrate the way we were trained. We're trained to think of the exception. If we don't, we are going to miss that one headache that comes in that's a meningitis or subarachnoid hemorrhage. So we're trained, and that's how we save lives, to think of what is the worst thing this could be, and then we take a history physical, maybe run some tests and prove otherwise. To do the work that we're talking about, we don't want to think of the exception. We want to think of what will work for most of our patients. So if we implement some of these interventions, and it only works for 50% of the patients, if it worked for 100%, we'd save 2 hours. Well, if it only works for 50% of the patients, we're going to save an hour a day, and that's not so bad. But to do this, we really have to take something off the plate, as the chair of medicine shared when I was ACP governor here in Illinois. We have great ideas, but I find that our colleagues are just so frustrating. They're just drowning that they can't even look up to hear what great ideas you have that could save them time. So what we encourage people to do is look at what we can do in the back room and take things off our colleagues and our desk. And we put the best of these into what we call a saving time playbook. And I'll show you the contents here. And this is part of the AMA Steps Forward program. Here's the contents. Part 1 is stop doing unnecessary work, which I'll highlight. The second is then incorporate, once you have some time and you're no longer drowning, think about reworking the workflow and embracing team-based care. And then we have to make the business case to do all of this. So quite often our computer is the scapegoat, but quite often we are often over-interpreting the rules. And we will highlight some of the AMA resources that show where we can go to the source of the regulations and see that sometimes we're shooting ourselves in the foot by over-interpreting. And in fact, Don Berwick wrote this piece showing that the vast majority of wasteful rules were fully within our own administrative control. So this is the landing page for the Getting Rid of Stupid Stuff toolkit, written by Melinda Ashton based on her piece in the New England Journal. And we know that physicians and nurses and your team know what they're doing that is really unnecessary and doesn't provide quality care. Included in this toolkit, in how to find the unnecessary work, is a de-implementation checklist that was developed last year. And we find that if you embrace some of these suggestions of stopping unnecessary tasks, you could save an hour a day. And when you add that up, that's 20 hours a month or 30 full working days saved per year per provider. Physicians themselves are often in the best position, and nurses and your MAs are often in a great position to see that there's duplication, that just with a little bit of reworking, we'd save a lot of steps. Sometimes it's a printer in the room. Sometimes it's using lean techniques to make sure everything in the room is in the same place in every exam room. Pretty basic things that we're not usually taught of in medical school. This is the entire de-implementation checklist. It's broken down into ideas in the EHR, like extending the time before automatic log off. That saves an enormous amount of time. Allowing verbal orders in low risk situations. And to make sure that quality assurance and improvement helps us save time and not adds work to our day. When an organization has done this, they were able here in Boston to save 60 million clicks, about 2 hours a day per provider. So this can be done by getting rid of copied tests that somebody else ordered, scanned, signed paper that you've already reviewed and went to the scanner is back in your inbox. Believe it or not, some organizations are still doing that. And though we have to be attentive to the Cures Act, we don't need 10 admission, discharge, and transfer notifications. We need one notification that a patient was admitted to a hospital so that we can follow up. And that can be batched and sent to a care coordinator instead of 10 different messages trickling in to your inbox asynchronously over the course of a week when you're not even going to see that patient until the following week. Another toolkit that I'd like to highlight is Taming the Inbox, and really rethinking not how we're going to empty the inbox, but go upstream. What shouldn't even enter the inbox? And I mentioned some of those notifications of a test being scheduled, notification of a lab being ordered without any results. Totally unnecessary. You know, even though it takes a second to delete it, it's a couple seconds here, a couple seconds there, and it's a distraction from the important work at hand. I used Epic, and I found that if I could go into a patient's chart and I could remove unnecessary notifications of tests that another doctor ordered. And this is a patient safety issue as well. My trusted cardiologist ordering electrolytes, I don't need to know what he's ordered. I trust that he and or she will take care of it. But if I'm copied on it and it's abnormal, is it my responsibility or is it their responsibility? It's not clear, and the patient could fall through the cracks there. So those can be turned off. When I did that, my inbox decreased by about 50%. There's a wonderful tool also in that with that vendor with autocorrect like we have on our iPhones. You can teach it to autocorrect to your common abbreviations that you've used over the course of your professional career. You don't have to do smart lists or dot phrases. Another great time-saving tool is changing chronic medication refills from 90 with one refill or 6 months to 90 times 4. Call me no more. If you start that today, you won't see the results for 6 months. But when I did that, and I was hesitant to do it because I didn't think my patients would like it, or they'd miss their appointment. But I freed up an hour or two a day. And in 6 months, I was not getting calls from the pharmacies. I wasn't getting faxes. Patients weren't sitting at the pharmacy waiting for that refill to be called in my inbox. Refill requests went down by half. When you do this, the physician can save an hour a day and a nurse could save 2 hours a day. So night calls, medication errors go back, patient satisfaction goes way up, and you continue to see the patients as often as you need to. And now you have time to follow up if patient misses the appointment. So instead of punishing all of your patients for the missed appointment of just a few, if you put this in place, you'll have plenty of time to reach out to those patients who missed their appointment. So here I'll summarize. We want to stop doing the things on the left, unnecessary refills, inbox, duplicate work, unnecessary password entries, so you can do more on the right. Build trust, build protocols, develop standing orders, educate the team, and maybe finish the work when the lights are out, not taking that 2 hours of pajama time documentation work at home that many of us do. I'm going to highlight just two. PreVisit Planning is a huge time saver. Some people start with PreVisit Labs as part of PreVisit Planning. When I did this, I saved easily an hour a day, and I implemented this myself in my private practice. Patients loved it, and I didn't have all those phone calls down the road, as you'll see with Mrs. Hughes as we demonstrate that. We can also have the patient and ancillary staff, licensed or not certified or licensed, actually add to the medical record. This is a new rule that the pandemic took our attention away from, but we fought hard for this, the House of Medicine, and we're not taking advantage of it. So the physician just needs to verify what ancillary staff or the patient has put into the chart. And we need to begin to do this. It saves an enormous amount of time. So the physician no longer needs to re-enter it. It can be entered by staff or the beneficiary, the patient, and the doctor needs to review and verify. And the Debunking Regulatory Myths page will send you to the document on CMS where that's sourced. So with some of these ideas, you can save 3 to 5 hours a day. What are you going to do with those 3 to 5 hours? Well, hopefully you'll get home on time. You won't be taking the documentation home. You will have another hour to work with your team to implement some of this more efficient work, more education, build that trust, and take that third hour and build trust with your patient. Because only if you have time and demonstrate that you care, which takes time, will you build the trust so they will follow your recommendations and share with you what their true medication taking behavior is. So this is, again, the slide I showed you with Mrs. Hughes without any pre-visit planning. And there's a million, dozens of things that need to be done. Those are there on the left in no particular order. But we want to choose one and get started today. So the next slide I'll show you with pre-visit planning. She was called yesterday. She had her labs done a couple days ago, and she has everything you need to take care of her when you see her today. She's already filled out her PHQ. You see that her numbers are better, so she's improved. You had time to take her off weight promoting drugs and put her on weight decreasing drugs, and her problem list is less, and her meds are less. Between this visit and next, none of these other trying to play phone tag occurs, so that hour or two is saved. Now, when she comes back 3 months from now, she's closer to goal. She's been to the diabetes educator because that's on the standing order. She's been to the physical therapist for her knee pain, and she feels great. You feel almost as good as she does because you know you've made an impact. You've decreased her risk of stroke, and she's living a fuller, more meaningful life. This is a list of just some of the 70 toolkits that we have that help you do this work. Again, no email required, no password, open access to all. And for talking about the staffing crisis, we have written one on medical assistance, recruitment, and retention. And there are opportunities for people who've been doing medical assistant work to sit for the exam. Many physicians don't know that you may have trained someone who's doing this work, but weren't aware that with your letter that states that she's been doing the work and passing a test, he or she can qualify and be certified as a medical assistant. Because what's wonderful is that the principal driver of physician satisfaction is being able to deliver great quality care. We just need the time to do it and not spend time doing unnecessary tasks. Here's a list of 11 quick wins that an organization might implement. But here's 10 that you can do this afternoon or tomorrow morning, the next time you see patients. You have total control over these. And just even taking one at a time can save you an enormous amount of time during the week. How do you implement it and make sure that it will continue? It doesn't have to, you don't have to have a quality improvement department. I just drew a 2x2 chart here where on the x-axis is hard to easy, low impact to high impact. And you want to try an intervention that is in the upper right, the yes column. It's easy and it's going to have a large impact on your team, on your time, and on your patients. And then set out with Post-its, think of some ideas. One simple one might be everybody wears a button that says, I got my COVID vaccine. Without saying anything, all your patients are aware that everybody on your team is a proponent of the COVID vaccination. Doesn't take time and can be very effective because you still are the most trusted resource of information for all patients regarding the vaccination. And then you put them where you think they would be fit on this 2x2. And you want to put things, work on things that are in the easy column and have high impact. And then again, don't need an Excel spreadsheet. Just track one intervention and see if it works. Maybe it's asking patients to bring all their medicines in so that you can do med rec. But whatever project you're thinking of doing, simplify it. This is the landing page for steps forward, and we're going to highlight some other wonderful resources from the practice sustainability teams. We want to work smarter, not harder, and we have a lot of resources to do that. But first, stop doing unnecessary work. And I'll end by sharing again that we can focus on efficiency with the staff we have, and in essence, double our staff. Get rid of stupid stuff first, the interventions work. And I will hand it over if you need more conversations like this or more one-to-one conversations about where to get started. We have a no-cost opportunity to do that called Mentoring for Impact that I lead, and we'd be happy to work with you over the course of 1 to 2 months to get started. And I'll hand it back over to Taylor. Thank you for your attention, and hopefully we gave you some ideas to take back some of the control over your day. You have control, Taylor.
Thank you, Dr. Brown. Those tips were so helpful. So now I'm going to talk about how we can plan for the workforce shortages. When COVID-19 hit us in early 2020, I was actually the administrator for a private practice just outside of Chicago. We had to plan very quickly for an environment that none of us had been a part of in the past. So during the next couple of minutes, I'm going to run through some of the options that increased efficiency in my small private practice that I was working with and several of the other small practices in our community in the early parts of the pandemic. So first, I want to touch on the newly revised Keeping Your Practice Open guide. The AMA just released this a few weeks ago, and it includes a wealth of information on navigating staffing issues and patient visits during the ongoing COVID-19 pandemic. Dr. Brown previously just touched on several of the benefits of the resources mentioned in this guide. And I'm going to take you through the next section, which includes tips on small changes practices can make now to improve their workflow. So some of the workflow and operational changes that can be made are listed on this slide, as well as in the previously mentioned guide. But these things include contacting the patient prior to the visit via phone or scheduling a quick telehealth appointment, as Dr. Brown said, for the pre-visit planning options. So pre-registration, getting any updates to their medical history, their medications, making sure that they have their labs done prior to the visit, and updating any of the information in the medical chart. Practices can also consider grouping similar appointment types together on the schedule. This increases efficiency and reduces the pivots during clinic for physicians and staff to have to switch between appointment types. And then also implementing separate clinics for high risk patients should also be considered for practices to reduce the potential exposure to this group. As we've heard probably for the past 2 years, minimal staff, minimal people in the office to reduce the exposure. So any staff that you can move to a remote position, that is a good option. And the AMA has created a work from home guide for private practices for certain tips and things that you can consider if you are going to move any of your staff to working remotely. You should also consider employee cohorts on alternating days. So this would be something like having certain staff work Monday, Tuesday, Wednesday, other staff working Thursday, Friday, so that the same staff is always working together and there's less risk of exposure. And then implementing an on-call schedule for the staff. So in the wake of unpredicted absences due to illness or testing reasons, several offices have implemented this. And so there's just 1 or 2 staff members that don't have to come into the office unless they're called. And then some examples would be they have a set amount of time from when they are called to when they have to get to the office. This is similar to the physician on-call schedule, but it's just being implemented for staff now to plan for those unpredicted absences and help make sure that you are not understaffed in your clinic when that does happen. And then finally, communication is key. As always, it's important to establish an open flow of communication that's easily accessible by all staff members in your organization to keep everyone on the same page and up to date with what's going on. And then let's talk about some workplace safety for the staff. So it is still a top concern for staff that come in close contact with other individuals. It's important to communicate personal health requirements clearly to your staff. So some of those are listed on this slide. I won't read them to you. But one important thing to mention is that all employee records on COVID-19 should be kept in a confidential employee file separate from their personnel file. And there is more information on this in the guide. Then in an effort to reduce exposure, consider rearranging open work areas to increase distancing between employees, implement assigned workstations to prevent cross-contamination, and identify the number of staff members permitted in shared spaces at one time to make sure that you are complying with the social distancing guidelines. So this would be common areas such as break rooms, things like that. And the private practice sustainability team has several resources available for practices on our webpage, which you can access via the link on this slide. The email address for the practice sustainability team is listed on here for any follow-up questions that anyone might have from this presentation. And the slide deck is available for download to access the links that I'm referencing here. And then also on this slide, There are several links here for things that Dr. Brown and I have talked about in order to help you really increase efficiency in your practice during the staffing shortage and do less with more. So you can click any of these links, and I know that there are a few on here that are not filled in right now, but the links will be accessible in the slide deck that's provided after this. And that is all that we have for everyone today. We just wanted to thank you again for listening in, and we hope that you have a great day or week, and we'll talk to you soon.